And welcome back, everyone. We do hope you had a nice break, maybe a little bit refreshing, maybe something to eat. Welcome to our next session titled The Radiotherapeutic Management of Colorectal Cancer. And we are joined by Dr. Jelena Lukovic. Uh, Dr. Lukovic is a radiation oncologist at the Princess Margaret Cancer Center and an assistant professor at the University of Toronto. She treats gastrointestinal, gynecologic, and endocrine malignancies. She has a Master of Public Health from Harvard University, and her primary research interest is in organ preservation. She sits on the National Cancer Institute Gastrointestinal Subcommittee Task Force and additionally represents the Canadian Cancer Trials Group on the NCPN Diversity in GI Oncology Task Force. It is an absolute honor to have you with us here today, Dr. Lukovic. Thank you very much, and I pass you the floor.
Thank you very much. It's my first time at this meeting, so it's really a pleasure to be here. I think my slides should be coming up shortly in a second. Yeah. Um, there we go. So maybe we can,
I think they are in presentation mode
yeah,
currently.
perfect. So again, thank you for having me. This talk really focuses on the use of radiation, primarily in metastatic colorectal cancer. We can go to the next slide. In terms of topics that we're going to go through today, we'll talk a little bit about the indications for radiation therapy, including palliation, local control, and cure. We'll go through an overarching radiation planning concepts, talk about indications for local treatment modalities, and then talk a little bit about these terms that you might hear in your clinics, oligometastasis or oligoprogression, what these are and what they mean for our patients. I will highlight my colleague, Dr. Rebecca Wong. Some of the slides in this presentation were conceptualized by her, and she gave this talk to the group last year. Next slide, please. So in general terms, colorectal cancer, which starts anywhere in the lower GI tract, can spread by local progression, meaning it grows around the area it starts. It can spread via lymphatics to lymph nodes. It can travel through the bloodstream somewhere distantly, like the liver or the lung, or it can spread via the peritoneum, that lining of our abdomen. It's considered to be a relatively radio-resistant tumor. And now for that means we try to give a higher dose of radiation for local control. That being said, something called MSI or microsatellite instability or MMR deficiency patients may be a bit more radiosensitive, so might respond a little bit better to radiation. Next slide. Radiotherapy side effects are due to normal tissues essentially seeing radiation treatment. So next slide, please. Next, yeah, so this is what a typical radiation therapy plan would look like for a patient with a rectal cancer. This is your lower pelvis. And all of the lines that are in different colors represent different doses of radiation. And this is why we get some side effects. So if we take a look at the bladder, for example, which is outlined in orange, the bladder sees a little bit of radiation, and for the patient, that is experienced as increased frequency of urination, maybe discomfort with urination, maybe something like cystitis. The small bowel, which is highlighted in pink, also sees a little bit of radiation, and the patient experiences that as diarrhea, loose bowel movements, maybe increased frequency of stool or urgency to get to the washroom. And then the lighter orange or yellowish color in this individual is an ovary. It's a very young patient, and so the ovary seeing radiation will lead to premature ovarian failure, and that means early menopause and everything else that's associated with it. So again, radiation therapy side effects are because there is a little bit of radiation that has to pass through all of these normal organs to get to where it needs to go to treat the cancer. Next slide, please. And normal tissues remember radiation. And what that means is there's a limit of how much radiation we can deliver to the same area over an individual's lifetime. These limits are different for different organs, but in general, they're not forgotten over time. And so that means if a patient got radiation, we're thinking about giving radiation again, we have to very carefully consider how much radiation we got, where did that radiation go, and what will the cumulative doses be in whatever we're trying to treat. Next slide, please. And when we think about broadly our indications for radiation therapy in metastatic cancer, there are kind of three big categories. On one hand, we have symptom palliation. So someone might be having pain, maybe their tumor is bleeding. We want them to feel better. We want to reduce the symptoms. We want to delay symptoms. In general, when we're using radiation in this setting, we accept fewer visits, we accept less toxicity risk. We want this to be as easy and as streamlined as possible. We can also use radiation for local control. So maybe there's one problematic metastatic deposit that we want to control for as long as possible. Or, and this is particularly relevant in colorectal cancer, is sometimes by treating metastases aggressively, we can lead to survival and a longer survival or cure. And in this type of situation, we might use higher radiation doses. We generally accept a bit of a higher treatment burden and maybe an increased risk of toxicity, balancing that with this outcome that we're trying to achieve. Next slide, please. And as radiation techniques have improved over time, our indications for radiation therapy have expanded as well. Next slide, please. So back in the 1940s, so quite a bit before my time, radiation therapy was done in 2 dimensions using something called a DRR, a digitally reconstructed radiograph. It kind of looks like an X-ray. And so what we did as radiation oncologists is we drew a box and we aimed the radiation through that box. Sometimes we use what's called shielding, so physical pieces of lead to shape the radiation. But in general, it was a pretty crude method of delivering it. Over time, as imaging this technology developed, we got the ability to do conformal radiation. So something like IMRT, which stands for intensity modulated radiotherapy, or VMAT, volumetric modulated radiotherapy, that's that picture in the middle, allows us to deliver lots of radiation to a tumor, but relatively little radiation around it, therefore increasing the dose we can give, but sparing the patient from some toxicity. We then develop what's called image-guided radiation therapy, and that essentially means we take a picture prior to each radiation treatment to ensure that things are lined up correctly, to ensure that we're aiming at the right spot. This has allowed us to reduce the volume we treat. We have particle therapy like proton therapy now. And then ART stands for adaptive radiation therapy. Next slide, please. So again, with these increased technologies, we've been able to get increased precision, increased doses to the tumor, and reduce normal tissue dose, meaning reduce toxicity. Next slide. So this is adaptive radiation therapy, and it's really the future of radiation therapy delivery. I can say at Princess Margaret, our goal is to have 75 to 80% of all of our treatments delivered using this technology within the next 5 to 7 years. So the way we classically did, let's just go one back, please. The way we classically do radiation therapy is we get what's called a simulation scan. Usually it's a CT simulation. So we take a picture of what we want to treat because everyone's body and everyone's cancer is different. We customize a radiation plan based on the patient's anatomy and the patient's cancer. And then we do the exact same treatment every single day. But the human body is extremely dynamic. Things on the inside change. So your bladder, for example, for treating the pelvis might be more or less full one day. The rectum or the bowel might be full of gas, might be empty. There might be stool moving through it. The tumor might be shrinking during treatment. So if we take a look, for example, the middle line, our IMRT treatment, we create one plan, but in the middle, you see the bladder is enlarged. We're still delivering the exact same radiation plan. So bladder is getting more radiation dose. The patient's probably experiencing more symptoms. On the other hand, with adaptive radiation, we create an entirely new radiation treatment plan every single day based on the anatomy of that day. And so if an organ such as the bladder is bigger, we can change the margins to adjust for that. If the tumor shrinks during the treatment, well, we can treat less. And so overall, this allows us to essentially be even more precise with radiation therapy delivery to adjust for all of these variations that we have in our bodies every day, to shrink margins and to hopefully improve the outcomes for our patients. Next slide, please. Okay, so moving on to some general radiation therapy planning concepts. So when we plan radiation therapy, this is broadly what we think about. Our GTV that's in red, that's the tumor, it's our gross tumor volume. The CTV is called the clinical target volume. This accounts for our subclinical or invisible invasions, maybe some microscopic cells that we can't necessarily see that are there. It's similar to the way a surgeon would take a surgical margin when they do an operation, and they want to make sure that there's no cancer cells left at that margin. That's what our CTV is. Now, I mentioned things inside the body move a lot. That's our ITV. It accounts for that. It accounts for the fact that our organs are moving as we're breathing, as gas is moving through the bowels, as the bladder is filling. And then our PTV, our planning target volume, accounts for setup error. So although we try our best to have the patient in the exact same position every day for treatment, it's not perfect. The PTV is usually a few millimeters to help account for that uncertainty. Next slide. In terms of doses and techniques, as I mentioned, we have different indications for radiation therapy in metastatic disease. If we're doing something very simple, purely for pain or symptom control, we might do a direct beam of radiation. Usually these are very low doses where we know that the toxicity is going to be low. On the other hand, if we're doing higher dose techniques, like something called SBRT or stereotactic body radiation therapy, we use very high doses in relatively few fractions. Next slide. So in both of these cases, we can have relatively conformal plans. Again, we try to aim to minimize toxicity as much as possible, but the types of doses that are delivered can be very different. Next slide. This is what an SBRT or stereotactic body radiotherapy plan might look like. What you see here is a liver, and this is a liver metastasis. So the radiation is aimed at the metastasis, which is shown in red. The green outline is that clinical target volume where we think there might be microscopic disease. And so all of that is getting a very high dose. That's represented by that blue line that goes around. And then the yellow, pink, blue, and orange lines represent progressively decreasing amounts of radiation. Next slide, please. So from a patient perspective, what does the patient go through when we do radiation therapy? Usually for a palliative radiation plan, so for example, for pain or bleeding where we want to treat pretty urgently, a patient would come in, they would have a planning scan. Usually this is a CT. Sometimes it might include additional imaging. Sometimes we use IV or oral contrast to help visualize the tumor. And then we think about immobilization. I'll show you a couple of examples on the next slide, but essentially we sometimes use a chessboard where the patient lies with their arms above their head in an armrest. So we have knee rests, head rests. Then the treatment planning process takes between 4 hours at the fastest to 48 hours. We generate a simple radiation treatment plan. It undergoes through a couple of quality assurance steps. During this time, the patient might wait at the hospital or they might go home and come back. Then they come back for their treatment. They set them up with that same immobilization as the planning scan. We do what's called a cone beam CT, so a quick CT to make sure everything is matching correctly. And then the plan is delivered. Next slide. So something new we have as of essentially this year or late last year is what we call a SIM-free workflow. So instead of going through these steps of having a planning CT and then waiting for this planning time, the patient actually goes directly to the treatment machine. And all of the treatment is performed in real time. So the patient will go, they'll lay down, they'll get in their immobilization on the treatment machine. A cone beam CT will be acquired. It takes just under 6 seconds to acquire this image. Then the contouring, so we define where the tumor is and where we want the radiation to go. The treatment planning and the quality assurance takes place. We take a second picture. Again, that's a 6 second CT scan to double check for the correct match, and the plan is delivered. Next slide, please. So this is an example of a patient that we treated with a SIM-free workflow who came in from an outside hospital with a bleeding rectal tumor. And if you think about it from a patient perspective, as an inpatient in a different hospital, you're transferred over via ambulance or via non-urgent patient transfer. Usually these patients are on a number of medications, possibly for pain, for other symptoms. They may or may not have a nurse with them. They may or may not have brought their medications with them. And so having to wait and lay in a stretcher for 4, 5, 6 hours while this radiation plan is being generated is really not ideal. In this individual's situation, we were actually able to treat her with our SIM-free workflow. So when she arrived to the hospital, we did a consultation and she went directly to the treatment unit. This is an example of the cone beam CT scan that was acquired for her treatment planning. She received her treatment and everything was completed with her en route back to her home hospital in under 2 hours. And importantly, her bleeding and symptoms were controlled. In terms of higher dose techniques, we really need to see the targeted normal tissues really well. And so if we're doing things like SBRT, we usually acquire more images than we would for simple palliative plans. We think about and worry about respiratory motion, and I'll show you an example on a different slide. And we have very limited tolerance for patient movement, again, because we're delivering these high doses. We want to make sure that we're targeting as accurately as possible. Next slide, please. So like I mentioned, there's different ways for patient immobilization during treatment. On the left is an example of a chessboard. The angles at which the arms stay up can be adjusted. The reason we like to have the arms up is because it gives us more range of freedom for the radiation beam to go in. We prefer not to have the radiation beam travel through an extremity if we can avoid that. On the other side is something called a backlog. It's almost like a giant beanbag chair that you lay in. The air gets sucked out of and it forms to your body shape. So for your next treatment, you're lying in the same position. Next slide, please. And why so many images? Because tumors are seen and might look differently on different images. And so when we want to give the most accurate type of treatment, we often need to acquire different types of images to help with that. On the CAT scan on the left-hand side, you see something that might be abnormal, but most of that gray looks pretty similar. On the PET scan, it doesn't actually look as bright as you would expect it to. The bright thing that's right in front of the arrow is the kidney. But on the MRI, we can tell that there's a tumor there is more easily delineated. And therefore, in this situation, an MRI might be most helpful for our planning. Next slide, please. On the other hand, in this situation, the tumor wasn't really well seen on the MRI, but was seen better on PET. So we use a combination of images to ensure that we're treating the right thing. Next slide. And so I mentioned motion. Motion is so important when we're thinking about SBRT. So like I said, things move in our body, and this is a picture of a patient with a lung metastasis. On expiration on the left, the lungs are empty. And then on inspiration, if you think about yourself, when you breathe in, your lungs expand. They go down, and so they push everything in the upper abdomen down, and your lungs go out as they fill up with air. So the tumor between inspiration and expiration moved 4 centimeters down. You can see that the liver, which is outlined in yellow, had completely moved. And so if we didn't have an assessment of the motion of this patient's tumor and of this patient's lungs, and we treated, for example, just based on what we saw on expiration, we would likely be missing, and our outcomes really wouldn't be as good. We have different ways to control for motion. One is called active breathing control, or ABC. It's a snorkel-looking device with a nose plug, and a patient is coached to essentially hold their breath, and this helps you hold your breath during the treatment. We have something called abdominal compression, where there's essentially weight or compression on the abdomen to reduce the amount of motion. And then we sometimes use medications like Ativan if a patient has someone coming back and forth with them. Next slide. This is just a closer picture of what these devices might look like. I have tried I've tried all of them, but ABC, or active breathing control, is quite challenging. Oftentimes we might ask patients to hold their breath and end expiration. If you try it yourself and you breathe out and hold your breath, it's really not easy to hold your breath for a prolonged period of time. And we ask our patients to hold their breath for sometimes for 20 seconds or more. The abdominal compression just feels like a weight on your belly. And so we can't use it for everyone. If someone has an ostomy, for example, we can't compress their belly. But we try to do it when we can. And if we use Ativan, the patient has to be coming with someone because they can't drive after getting this medication. Next slide. So let's talk a little bit about different indications for local treatment modalities. Next slide. We have a number of different local treatment modalities, and I believe there were some sessions that were targeted at some of the other ones on this list. This is an example of a liver, metastases in the liver. They can be treated with surgery. They can be treated with radiation therapy. There's something called radiofrequency ablation, MR-guided focused ultrasound, and then cryoablation as well. Next slide. And so why do we do this? Colon cancer is probably one of the first cancers for which there was evidence of improved outcomes when we aggressively treated metastatic disease. This is an article from 1984, so quite a long time ago, of 141 patients with metastatic colorectal cancer. And if you take a look at the survival graph, the patients who did not have surgery did not live as long as the ones who had surgery, where the surgeons went in and removed the metastatic disease. Next slide, please. There's been a lot of studies since then. This is an example of a meta-analysis. So a study that put together 45 papers with over 20,000 patients who underwent surgical resection. And so what they found was that for patients who had small levels of disease, whose CEA levels weren't too high, who had only liver metastases, only one liver metastasis that was small, and who had that resected with positive margin, tended to live longer. Next slide. And in terms of radiation dose, we know that dose matters. As I mentioned at the start of the talk, colorectal cancer is thought to be relatively radio resistant, meaning that when we can, we try to deliver higher doses of radiation because we know that leads to better local control. This is pooled data from our center along with center in Colorado and Stanford. And what we found was that for patients who received BED, stands for biologically equivalent dose, greater than 117, had a really good local control at 1 year, meaning that the cancer stayed under control, did not progress, did not grow. Whereas when lower doses were achieved, that was quite a bit less. Next slide, please. Location matters as well, though. And like I said at the start, our normal tissues that see radiation is how our patients get side effects. So if there's a tumor like the green ones, the liver is outlined in yellow, those tumors are away from important structures. It's pretty easy from our perspective to deliver a very high radiation dose. On the other hand, we have the tumors in red. The one in red that touches the pink structure is the stomach. And in the second CT scan, that cyan blue color is the duodenum. Both the stomach and the duodenum are very sensitive to radiation. And so the amount of radiation we can deliver to that tumor is limited by the fact that the radiation needs to pass by those structures. And things that we worry about when we give too much radiation to a luminal structure like the stomach or like the duodenum are very serious complications like ulcers or tissue necrosis or a fistula, which is a hole or a communication that shouldn't be there. Next slide, please. So in terms of our side effects, in general, patients tend to experience fatigue when they receive radiation, and then the remaining side effects are location specific. When we treat the upper abdomen, nausea and vomiting are quite common. We generally give prophylactic antiemetics like ondansetron to help with that. Gastritis can happen. Diarrhea, again, because of all the small bowel in the upper abdomen that sees radiation. And sometimes we'll see some liver enzyme abnormalities as well. Next slide, please. Now, late side effects. Late side effects are things that can happen many months to many years after radiation therapy. Generally, grade 3, so significant toxicities, are low with high quality radiation therapy planning and with IGRT with image guidance, where we're again making sure that we're targeting the right area. But we have seen things like bleeding, perforation, so a hole or an ulcer, which are surgical emergencies. We've seen fractures. So the liver sits right underneath your ribs. So sometimes if we're treating a tumor very close to a rib, we'll see rib pain or rib fractures. We've seen neuropathic pain. We've seen aneurysms, bleeding, and then liver, lung, or kidney injury as well. And so something that we think about when we're planning is, like I said, the location in relation to the organs on our planning scan, but also noting that everything moves. And so if we take a look at that picture of day 1, so our tumor is in red, our liver is the blue triangle. I'm not very good at art. And the orange is our bowel. It looks far enough away from the bowel on day 1. But on day 2, the bowel has come right into that high dose region. So when we're doing radiation therapy planning, we try to consider all of these things conceptually. Again, adaptive radiation therapy, which takes a picture at the time of the treatment, addresses things like this. But with one standard plan at the front, we would probably err on the side of safety, knowing that the bowel is so close, we would likely give a lower dose to this tumor to make sure that a serious toxicity doesn't happen. Next slide, please. Other local modalities for liver-directed therapy, I'll highlight quickly. We have TACE, or transarterial chemoembolization, and then Y90, which is yttrium 90. It's a radiopharmaceutical. They're essentially tiny spheres that are injected, and they have a very short range of irradiation. So they kind of have this embolic effect when they're injected into the liver. Next slide. Some factors that we think about when choosing liver-directed therapies. Do we have a few or multiple metastases? Are there metastases elsewhere? Can we resect? So can a surgeon go in and remove part of the liver and therefore remove part of the disease? And how much leftover liver do we have? The liver regenerates and you can live with part of your liver removed, but you can't live with all of your liver removed. And is that part that's going to be left healthy enough to sustain you and to sustain your further treatments? Is the tumor small and if not close to vessels? Is it close to luminal structures, again, like the stomach or the duodenum? And what is going on with the primary cancer? Next slide, please. So beyond the liver, we give radiation therapy to treat a number of other organs. Next slide. So this is an example of lung metastases. Again, we can do either SBRT, so that high dose precise radiation therapy, or simple radiation therapy like 8 gray and 1 fractions to 30 gray and 10 fractions. Usually lung metastases are asymptomatic, but sometimes, particularly if they're closer to the central structures in your chest, they can cause hemoptysis, coughing, or shortness of breath. In terms of side effects, most patients, like I said, experience fatigue with any type of radiation. They might get esophagitis. The esophagus is that swallowing tube connecting our mouth to our stomach that can get irritated from the radiation treatment. There can be some airway irritation manifesting itself as a cough. Next slide. We can palliate the primary tumor. So sometimes a patient might present with metastatic disease, but that primary tumor is causing problems like bleeding, like pain, like obstructive symptoms, so difficulty with going to the washroom. And depending on everyone's different, and I think everyone's very unique in terms of the type of treatment that they ultimately get. But generally, depending on the extent of other disease, so if there's one, for example, on the left side, there's one metastatic deposit in the liver, let's say, we might treat with a longer course of chemoradiation, so 5 weeks of radiation with the chemotherapy pill, and then do surgery on both sides, probably with chemo, either before or after. Or if there's a lot of metastases, like the picture on the right-hand side, we might do chemotherapy to address all of those regions and give a shorter course of radiation for local symptoms. Next slide, please. For bone metastases, the most common symptom is pain, and they can cause a pathologic fracture. They can also cause a spinal cord compression. A spinal cord compression is tumor that's pushing directly on the spinal cord, and that can lead to symptoms like weakness or numbness in the extremities. If you have a cauda equina syndrome, it can lead to urinary retention, incontinence of the bowels, as well as saddle anesthesia. Generally, we prefer to do SBRT, so high dose precise radiation therapy to the spine or to the bone. In terms of the spine, we have a big Canadian randomized trial that showed better control and better outcomes for patients with this. And we have a trial that's currently ongoing that's exploring SBRT in other bony sites other than the spine. In terms of side effects, pain flare is the most common. It happens in about 15 to 20% of patients. It can be mitigated by a medication called dexamethasone, which is a steroid medication. Usually we give a short course of that, 5 days along with the radiation therapy. Next slide. For brain metastases, and these are relatively less common in colorectal cancer. When they do happen, we can have surgery as an option where possible. And then we have stereotactic radiosurgery or gamma knife. It's a very precise treatment, usually one single fraction. And you can see here this big contraption that's sitting on the patient's head. Essentially, immobilization is so important, especially when we're treating a very high dose to the brain. We want to make sure that the targeting is as accurate as possible. Generally, it's very well tolerated with some minor hair loss, neurocognitive effects, and the risk of cataract is actually quite low. Next slide. And finally, for other sites, we can use radiation for symptom control, essentially head to toe, for bleeding, for pain, for lymphatic obstruction or mass effects. When we think about whether or not radiation therapy would be appropriate for symptom control, we think about what the symptoms are now, or maybe what do we anticipate the symptoms to be? Are there treatment alternatives? What are the side effects? And most importantly, what does the patient want? What's their preference in terms of treatment? Next slide. And finally, I just want to touch on oligometastasis and oligoprogression, and what it means. So oligo means few, poly means lots. There is debate in the literature as what defines an oligometastatic state. Most papers will say 5 or less metastases. So on one hand, we have one single metastasis. On the other hand, we have one metastasis, but we have a lot of other micro metastases. Go to the next slide, please. And so it's this paradigm where, historically it used to be thought that metastatic disease, once cancer spreads beyond where it has started, cannot be cured. And this was the term oligometastasis, and this idea, this intermediate state, was first discussed in 1995 in this seminal paper by Hellman and Weissenbaum, when they said that maybe there's this intermediate state between local and systemic disease where a radical treatment of the primary cancer and all of the metastatic lesions might have curative potential. So if we have, say, a rectal cancer with one or two liver metastases, maybe we can cure this individual. And this type of presentation is very different than, say, a rectal cancer and metastases in multiple metastases in multiple organs. The other definition, or the other term that you might hear, is something called oligoprogression. And this means that a few lesions on a background of widespread metastatic disease are progressing. There's a lot of different conditions, but it's, if you think about, someone might have metastases in their liver and their lung, they're on chemotherapy or immunotherapy, everything is going really well, but there's one spot that starts growing or changing. Sometimes it makes sense to treat that one spot that's changing because the chemotherapy or systemic therapy is working everywhere else. This way you can stay on the systemic therapy for longer. The evidence behind that is not as defined as the evidence behind treating oligometastases aggressively. However, we do it quite often. Next slide. Yes, and pictures. Next slide. There are a lot of different trials that have been published in oligometastatic cancer, including trials that were open here. Saber Comet, which is the trial listed at the bottom, it was a Canadian trial that was started in London, Ontario. The PI was David Palma. Essentially, what they did was, it could be any site of tumor, so it wasn't just colorectal cancer patients. Most patients had only 1 to 3 metastases, and they received SBRT or SABR. Those terms are interchangeable to those 1 to 3 metastases, and they found there was an improvement in both progression-free and overall survival in this scenario. Next slide. Again, a phase 2 trial. This is, sorry, just highlighting what I talked about. We also had an in-house trial at Princess Margaret that was published a few years ago by Dr. Wong, who again gave this presentation last year. We looked at how patients did when we gave ablative or high-dose radiation therapy to all lesions. Next slide. And we found that the local progression rate was really favorable. Patients with a few metastases had better outcomes, but distant failure still tended to be quite common. Distant meaning that the patient develops another metastatic spot outside of the one we treated, suggesting that local treatment by itself might not be the right thing for everyone, but certainly was helpful for a lot of people. Next slide. And in terms of patient-reported outcomes, there was an improvement in quality of life and our ESAS scores in patients who did not have progression. So better quality of life and lower symptoms advocates for considering this type of treatment. Next slide. Again, favorable local progression-free survival is accompanied by the preservation of quality of life and avoidance of symptom progression, which is great. And patients needed fewer cycles of chemotherapy or immunotherapy at 12 months after their treatment. So again, being off treatment is nice. And this is something that was achievable within our study. We certainly need strategies to improve patient selection. And again, information on symptom burden, on quality of life, as well as the pattern of antineoplastic therapy use. So the use of chemotherapy or systemic therapy after progressive disease is really useful in these conversations between patients, families, and healthcare providers. Next slide. So oligoprogression, again, this is that scenario where there's widespread metastatic disease, but we have one or limited sites of metastases that are growing. We have a number of different trials that are looking at whether or not doing this type of therapy improves outcomes for our patients. Usually does it improve something called progression-free survival, although the suppressed trial is looking at overall survival as well. Next slide, please. And so this is really one of my summary slides. How do we approach this? We think about the patient, and then we think about their cancer. So what is this individual's performance status? How well are they? What's their life expectancy, both with the cancer and outside the cancer? Some people have lots of comorbidities and issues, other people don't. And how many metastases are there? Are there a lot? If they have a more favorable prognosis, then would there be a dose response? Can we get this? If yes, we'll give a high dose of radiation and try to control things for as long as possible. On the other hand, if someone's not feeling as well, if someone's maybe bedbound, having a lot of symptoms, and we can make an impact in their quality of life by helping with their pain, by helping with their bleeding, so they're not at the hospital getting blood transfusions every week. We might give a low dose, try to minimize their time in the hospital. Next slide. And then we look at oligometastasis factors. So again, if there's few metastases, they're in a location that we can safely and effectively treat, we again give SBRT or other ablative high dose options. But if they're on the larger side, there's more, we might consider closer follow-up and weigh the balance of toxicity and treatment burden. Next slide. So in conclusion, I think I'm right on time. Radiotherapy is indicated for a broad range of indications in colorectal cancer with metastases. The treatment intent, obviously, along with patient preferences, drives our dose fractionation. So how intense of radiation are we giving? What technique are we using? And what treatment burden versus risk of side effects are we accepting? The choice of sequencing with radiation with other treatments really depends on the distribution of disease, the patient's performance status, what is the biggest problem right now. And really multidisciplinary and joint decision-making is core to our treatment plan. Next slide. I think that is all I have. I will open it up to questions.
Thank you so very much, Dr. Lukovic. And yes, you're absolutely right. You're within 2 minutes of exact time. So thank you so very, very much. That was a wonderfully informative presentation. And we do thank you sincerely for being here and to help educate us today. So thank you so much for your time. Our coaches will now head backstage for their question period with Dr. Lukovic, and our silent viewers can now head back to the lobby until our next session, which will be at 1:45 Eastern Standard Time after a lunch break. We do hope you enjoy it, and we will return back with our session with Dr. Marsden. We will see everyone at 1:45.
Do I click enter backstage?